In this episode of Leadership in Digital Health, we're talking to David Hansen, CEO of the eHealth division of CSIRO. We talk about what clinical terminologies are and the role of Ontoserver in making the management of terminology so much easier, and the recognition that solution is achieving on a global stage. I'd like to welcome David Hansen, who's the CEO of the eHealth division of the CSIRO. Hi David, how's HIMSS going for you so far?
It's great to be here, actually. It's amazing to see so many people here. I think we're talking about 30,000 people, and there's certainly a lot of companies doing a heap in the digital health space. So it's been good to be here.
Wonderful, and you'll certainly hear the hubbub that's certainly going on around us. All right, so one of the major reasons I would imagine that the CSIRO is here is to be talking to the industry about Ontoserver and terminology services in general. Can we just take a little moment to talk about Ontoserver's purpose and the problems that it solves for the industry?
Yeah, sure. So Ontoserver is probably the best implementation around the world that we know of the terminology APIs of the FHIR standard. So that's where we've aimed it. That's where we're looking to take the pain away from implementing all of the really complex reasons why you'd use something like SNOMED CT or LOINC or any of the medicines terminologies. So we've tried to hide that complexity behind the FHIR APIs and really enable the increased use of standard terminology in our electronic health devices.
Yeah, brilliant. So let's talk about what the terminologies actually do and what the names of them are. So we'll take SNOMED CT as an example, and Australia with the National Clinical Terminology Service, has chosen SNOMED CT and the Australian variant of that, and that enables the identification of all sorts of things in an EMR or a clinical information system, like procedures and conditions and allergies and so forth in a standard way, so that System A and System B can recognise the same concept, whether it be systolic blood pressure or temperature or whatever it happens to be.
So I think that exchange of information, so sending information from one system to another system, of course, is the key to interoperability across our healthcare system. But we really want the data that's being exchanged to be able to be used by the second system as if it collected the data. And the only way you can do that is by ensuring that we're using the same language in the technology, in the data as that were exchanged, and so that the system can know exactly what the data is.
And you mentioned that FHIR is a part of what Ontoserver does, and so that means that to actually ask Ontoserver for the code for a particular concept, you use a FHIR API call to ask for it and to receive it back to the system.
We do, and what's been exciting being here at HIMSS, we're here, of course, as part of the Fireball booth. So Fireball is a business alliance of FHIR companies that are looking to promote the use of FHIR and open standards and hence increase interoperability. And what else is what I think we're seeing all around the HIMSS exhibition hall is the chatter about FHIR and how many companies are starting to use FHIR in their products, for their products, underpinning their products. So it's great to hear that. And yes, so what we've done is to implement the FHIR terminology APIs. What's great, of course, is that those APIs, and one of the great things about FHIR is it's based on modern web technologies. So whether it's RESTful web services or JSON or all these other things which new graduating computer scientists know, so that they can. So we're hoping that FHIR's lowered the barrier to being able to increase our digital health workforce. It's a workforce that certainly in Australia we really need to build on. And so the idea of having a really open set of APIs, and certainly in the terminology area, it is the FHIR set of APIs, but we've got lots of people who are using Ontoserver who aren't using it within a FHIR context. And so whether it's open air or their own clinical tools that they want to use, which aren't FHIR but they need to use terminology, we can support those use cases too.
And there's a lot to dig into there, and I want to come back to workforce considerations and to interoperability. But what you just spoke about there, where Ontoserver can be used even if it's not a rich FHIR ecosystem, it can be used regardless. What happens when you don't have a terminology server in place? What kind of challenges do organisations run into?
Yeah, so what we see is that one is around implementation of something like SNOMED, which is a complex ontology with lots of concepts, have lots of properties, and you can certainly do a quick flat file implementation where you've just put everything into an SQL database and query it. But then the user experience doesn't really support the clinician or whoever's entering the data in making sure that we're capturing high quality data. So, for instance, if there's well over 100, I believe over 200 concepts in SNOMED which have diabetes as a word in the concept or the description, and so if you're not treating that sensibly, and then it just lists them in that kind of alphabetical order. And so it's not a particularly good implementation. We'd probably call it a bad implementation of SNOMED into that tool. So what we really try and do is take into account context. So is it looking for a clinical finding or a complication or whatever, and then what are the most used concepts that we try and promote up so that the clinician can start typing diabetes. He gets the ones towards the top of the list which are most relevant, and he can select very quickly and move on to the rest of what he's doing at the time.
I'm sure that every clinician listening will have had the experience of typing the first few letters of a provisional diagnosis and having a drop-down box with several hundred options in it, and just picking the first one.
That's right.
And so, with Ontoserver, there's that value add where you have the option of defining value sets.
Yes. So
only in that value set can the appropriate options for that particular user and the work they're doing be presented, and a prioritization so that the most important stuff's at the top.
Yeah, and the way we've implemented it, you can just say only let people select from this value set, or you can say let them select from wider SNOMED, which is sometimes important. The long tail of clinical diagnoses or clinical findings is actually really important. So we don't want to lose that, but most of the time the clinician will want something from the value set, so those terms get promoted to the top in any search strategy when they're using Ontoserver.
And so by having that capability combined with good design for good user experience so that it's quick and it's effective to make that more precise choice at the coalface of care, that really helps downstream, doesn't it, in terms of analytics and interoperability and everything else, because you've got the most appropriate choice, whether it's a diagnosis or a test result or whatever it happens to be. You've defined the data in the most precise and appropriate way possible.
Yeah, and look, we're very much pushing the idea that collect once, use many times. But that means we need to collect really well at the point of care, right? So how do we enable our clinicians and clinical workforce to collect really well at the point of care, and then use that data throughout the healthcare system, right up to the population health level. So, I think one of the things we're looking at doing is how in Australia we've been on the digital health journey 20, 25 years now, even a little bit longer in the GP space, and how do we get better at using the data which is captured at the point of care to inform our population health statistics. At the moment, a lot of that involves a lot of manual munging of data and manual coding and all that sort of thing. Whereas really, as more and more of our hospitals come online with electronic medical records, we really should be using AI and grouping technologies and other things to make sure that we can use that data all the way through the healthcare system.
And it is a pivotal time in the Australian landscape, because a lot of our healthcare system is undigitised, and there'll be choices made in the coming years about which systems will be selected. And so it really is an opportunity to establish good fundamentals when it comes to data models and interoperability and terminology services.
Yeah, and look, there's we believe that really needs to be a community process. This is some work we've been doing with a couple of different groups. We've done a project over the last couple of years around GP data exchange. And that's been, and again, we're driving that using the FHIR standard, where we say, what's the data model and what are the clinical terminology value sets, etc., that we really want to be using in the GP sector. Let's agree on the data model and the terminologies for individual fields, so that we can have the correct value sets, etc. But do that from a bottom-up approach. And then we've got something which we can then say, as an industry, we're going to use, we're recommending that this is the implementation guides for data and for terminology that everyone uses. So we've run that process with industry and clinical groups, which overlap and contribute knowledge to each other and understand what the requirements are. And those things, we've actually published the first version of the implementation guide for that, just so that we can actually, as a community, all agree what those standards are, rather than having someone on high going, this is what you're using. Actually getting everyone together is really important.
Yep. And so what's kind of cohorts or groups of terminology sets were chosen for that foray into primary care?
So well, everyone's happy to standardise on SNOMED going forward. So then it's a matter of working with the terminologists from us and the agency and the state health.
Was there a particular case mix that was of interest? Were you looking to, chronic disease or?
So there is in some of our projects where we're building a specific one around Indigenous, where we're starting to look at what the social determinants of care are. So that's other value sets which we'll need to bring up as well, and which will be useful right across healthcare, of course. And then yes, so what are the most common diseases, both chronic diseases as well as acute that we're seeing, how can we promote those, etc.
And so, and that sounds fantastic. And the implementation guide, of course, will help from a programming perspective as well as a human perspective for everyone to understand what the specific FHIR concepts and terminology concepts are that need to be captured and how they're captured, so that they can all come together into a common data set. No matter the choice of vendor, of technology, of system. So it's a really whole of healthcare sector approach.
Yeah, and look, I have to sing the praises of the vendors. They've been fabulous. They're looking at how they can be not just supportive, but actually in there driving the process and working together. And it's a bit, I think in a business sense, pre-competitive. They know that, or they're keen to make use of the increased amount of FHIR resources which are available to help them build really good software, including Ontoserver, of course, and as well, part of the process actually enabled them to do a lot of building up of their workforce's knowledge around FHIR in a really safe environment. So they were sitting there with their competitors, but everyone was learning about FHIR. Everyone was agreeing on how they would be implementing that exchange of information.
And I think that's really important to recognise, is that there's no good guys and bad guys in this, whether it's vendors or governments or management or industry groups. All of us are in this for the right reasons. We just have different pressures and stakeholders for whom we need to solve for. And so that's why I think leadership in digital health and establishing ways in which we can all work together in a coordinated fashion is the secret sauce. And I think that what you've just described there is a fantastic example of the system working in a way that will benefit vendors and healthcare providers and those that fund the system.
I totally agree, and I think there's a certain maturity to the sector which is coming, and it's I know going way back there are a lot of GPs who started building their own systems, and we've matured since then to be a really mature software sector, and I think this increasing standardisation is another part of that journey, and it's really great to see the industry in Australia taking those steps. I think, coming back to workforce, there's still workforce pressures. Finding software engineers who have experience with FHIR and know about FHIR is still difficult. And of course, just at the moment, we're going through a huge expansion of how we want to use digital in healthcare and in interoperability, particularly driven by, I think, the pandemic over the last couple of years and the need to exchange data. And so there's a lot of demand. It's partly why we're working with the University of Queensland, for instance, to introduce a digital health software project course where we're teaching young software engineers about FHIR and SNOMED and all those other things, so that we're building up the workforce. So it's a really important thing what we need to do.
Yeah, I also believe that's vital, because it has been in the software provider side of the industry that I've worked in. It takes quite a while for engineers to get up to speed with any particular system.
Yep.
And the new data standards that are flowing through and are gaining maturity and are gaining acceptance. There's a learning curve there, but it's a learning curve that we can essentially pay for as an industry once.
Yep.
And then kind of, the rising tide lifts all boats. We'll all have it and can start to focus on the real healthcare problems rather than translation between different systems.
Exactly.
I would like to see at the university level that healthcare is attracting the best and brightest by learning these standards, compared to, there's plenty of other industries out there, right? There's finance, there's energy, there's...
And in fact, I believe that the number of IT graduates over the last 5 or 6 years has almost doubled around Australia, and I'm not seeing a lot of that in healthcare.
That's right. Healthcare has to compete really vigorously.
Competing with, lots of companies out there, whether it's finance or mining, just general software, of course. So there's lots of competition for good talent out there. Hopefully it's easing up a little bit, and we're starting to get more people interested in health. And of course, the great thing about what FHIR has done is that it's lifted the standards for digital health out of kind of the HL7 V2 world, which is really 1990s computer science, up to using modern web technologies, JSON and REST and all those sort of things, so that we can easily take engineers from other industries and without having to train them on totally new things.
That's right. And then that cultural shift, it leads to so many advantages in that, yes, you can bring the workforce in and they can become productive far more quickly, but it also powers the kinds of software experiences that we like to use. Being able to pick up our phone and our tablet, use it securely over the internet to find the clinical information that's useful to us right now. And it's that technology paradigm shift that enables that to happen versus the 1990s style approach where you had to be in the hospital in front of a keyboard and a monitor and a mouse.
And look, I think the big change over the next 5 years, hopefully we're starting to put the foundations, really good foundations in place with what we're doing with FHIR and SNOMED. And that's really going to enable this AI revolution, which is also coming, right? We've seen the incredible public discourse around AI driven out of ChatGPT. And like ChatGPT is great, but large language models have been around for ages. And so this is just, it's been really fascinating to watch the discussion that ChatGPT's triggered in the general community about AI. And, there's nothing really, I hesitate to say nothing really new, but these large language models have been around for a while. We've been using them for some of our projects, and but to see that general interest and general, how are we going to use this technology, and really the fact that we'll have much higher data quality mean that what we are able to do with large language models and other AI models will be much better. So I think there's hopefully there's a confluence of improved data quality and improved interoperability across the healthcare system coming at the right time, that we can start to think about how we use these new AI tools appropriately and ethically and all those sort of things in healthcare.
Yeah, now, there's a real sequence in there, isn't there, in that whether you're wanting to get useful data, quality data to train an AI so that the AI is sensible and useful and valuable, whether you want to do large-scale analytics, whether you want to enable your organisation with some automated clinical pathways. Fundamental to all of those working and being able to move at pace to get them started is having a data model that everyone understands across the industry, and having all of that data properly identified with industry recognised terminologies like SNOMED CT, like LOINC. Let's crystal ball gaze a little bit and let's fast forward to 2025 and imagine that now in 2023 that the regulatory authorities in Australia had said, okay, we are going to mandate that electronic care systems in Australia need to read and write with FHIR, need to use these terminology services, and it has to be done by this particular date, and we're a couple of years past that. What does the industry look like then? And let's talk about Smart on FHIR and in that context. What can clinicians and healthcare providers see as a consequence of locking in those standards now?
Yeah, so firstly I'll say it's really important that if we do go down that road of mandating, that we go through that community process so that we get the clinicians and the technologists building those standards together, which they then agree is what they're going to do, and the government says yes, we're happy with that approach, because then you get the buy-in, right? If you try and force people to do things that they don't understand why, or they're not happy with, they haven't agreed.
It must not be done to them. It must be done with them and by them. With us and by us.
That's right. 2025, I think, is ambitious, but I would hope by then we've got a lot. We've been building the community, and us and the agency with their interoperability plan, lots of others, the Department of Health, all of the state health departments, all of the vendors are actually really forming these communities, which help us get to implementation guides, which support chronic disease models and trauma, or any of the healthcare, Indigenous health, rural and remote, all those things where we need to be exchanging data in a really great way. Crystal ball gazing then, I really do think AI is going to change how we're doing things, as we just talked about, how that high quality data really enables a good AI experience. And so I think, one of the hardest things, I think you'll agree, Mark, is implementing an electronic medical record, or implementing, and I know that our state health departments in particular spend a lot of money implementing electronic medical records. They're only a tool. Then you have to go through all the change processes and build on top of the tool to make them really useful. And it's almost a case of you need to invest again the same amount of money to really reap the benefits out of doing it. So that's where you then need to work with administrators on how we're using this data to make the healthcare system efficient. How we monitoring performance or patient flow through the hospital, how we identifying bottlenecks for clinicians. It's how am I getting proper alerts, or how am I using things like large language models to write my discharge summaries, or all those other things. And of course, further down the line, or maybe not, there's going to be things like genomics and how do we deal with wearable data from patients' wearable devices, and all that new data sources where we need to be thinking, how do we want to handle that in the healthcare system? Do we want patients sending in the data from their Apple Watch or their Fitbit to the GP before they, the day before they come in, so they can have a look? Or what AI algorithms are we building that can do some analysis of that wearable data before they come in? Genomics, of course, is as rare disease and cancers. We're going to need to analyse that to find the best way of treating people.
The opportunities are absolutely endless. And when I say 2025, I don't do that in a glib fashion, because it is ambitious. It is short term.
Which is great.
But if we don't establish these kind of clear industry guidelines, then it pushes back all of those other truly valuable gains that will flow on from that. And so sometimes I liken it to the state of the World Wide Web 20 years ago, where everyone had their own browser, they all rendered web markup in different ways, and this site said best on Internet Explorer, this site said best on something else. And by establishing common web standards and coming together and doing that and continually revisiting them, not just doing it once and then leaving it for 10 years.
There's a maintenance cycle to these things.
Then what we have now is websites that generally work on all of our devices.
Right.
It enables the internet economy that we depend upon on an hourly basis as we order our rides and our food and our groceries and our furniture. And I see the same prospects and potential for healthcare, but we do really need to firmly establish those fundamentals, don't we? So as we draw to a close here, I'd just like to ask, what's next for the CSIRO? I know that there's more in the pipeline than Ontoserver.
Yeah, so we undertake research in the Australian Health Research Centre, from genomics and medical imaging through to all our interoperability and data analytics work through to mobile health, telehealth, virtual care. We've got some great initiatives coming up, obviously in the interoperability space, and it's been exciting to be a bit at the centre of that for Australia and to really show the value that CSIRO can bring to the Australian healthcare system. But we're involved in the Genomics Health Alliances around Australia, and so we're keen to see that as one of the next things to maturing. And some of our imaging work, which has traditionally been enabling clinical research, our clinical researchers are now starting to say, actually, we want to use this clinically. So whether it's a tool for helping to diagnose Alzheimer's disease or monitoring cerebral palsy through MRI images, etc. So there's a lot of work going on, and we're pretty excited about what's happening.
Oh, wonderful. I couldn't be more proud of the work as an Australian organisation that's happening, and something that really is front and centre at this this very big Global Digital Health Conference that we have here in Chicago.
Excellent.
Thanks very much for your time, David.
Thank you.